I'm gonna. Hey, this is Dr. Bill with Just the Tip and bringing you our new segments on urology school. We're going to talk about benign prostatic hypertrophy, BPH. There is a great segment on medical and surgical management. In this segment, we're going to talk about medical management. You can find that in the AUA website under core curriculum. You'll find that BPH is a big part of your urologic clinical experience. When you look at the website information, look at some of the tables and have a comfort level in the different class of medications. And then after that, you can hunt and choose the medications that you use in the clinic and categorize them. And so you're also going to hear different concerns about BPH from your patients. The vast majority of prostate problems is not cancer. It is enlargement of the prostate. And that results in complaints of bladder dysfunction. People call it lower urinary tract symptoms, or LUTS, or BOO, bladder outlet obstruction. You'll hear a variety of terms. When you are conceptualizing the problems with prostate issues and trying to explain the dynamics of BPH to your patients, you can use terms that are familiar to the patients, like a big orange with a big, thick orange peel, and that relates to the prostate capsule. And look at the wedges of the orange that are the obstructive component wrapping around the urethra or the tube right through the center of the orange. And so to alleviate complaints of voiding dysfunction, we want to impact the capsule of the orange peel, and we want to impact the wedges of the orange. And we can do that in a variety of ways. And when you're reading about the treatments, look at that image, and that will help you remember certain things. Some of the things that we do in our clinic to evaluate prostate and bladder size is cystoscopy, or using a cystoscope, a small telescope, often flexible, that's placed in the urethra, and that's a mainstay of urologic clinical evaluations. Also, we will use urodynamics, looking at the volume of the bladder, how much urine the bladder holds, looking at the pressures in the bladder and the urethra and the pressures around the prostate that makes urine flow or impedes urinary flow. So remember that there are new dynamics and there are new concepts in evaluation of pelvic anatomy and bladder dysfunction. So you're going to learn about behavior modification, over-the-counter herbals that are advertised to shrink or relax the prostate tissue. A class of medications called alpha blockers that work on the bladder neck and the prostate capsule itself. These actually don't shrink the tissue, but relaxes it. 5-alpha reductase inhibitors, another class of drugs that are touted to shrink prostate tissue, or combination therapy. Then we look at anticholinergics. Remember from last lesson, there are cholinergic nerves that stimulate the bladder. And what that does, if we use anticholinergic nerves, that will actually relax the bladder. Using a new class of drugs that we have used for erectile dysfunction, PDE5 inhibitors. We found that there is value in not only treating sexual function, but treating bladder outlet obstruction as well. And a new class of drugs, beta-3 agonists, which relax the bladder tissue in a totally different way. So there are a variety of medications, a variety of treatments that we're going to utilize. And we have found that using a variety of these medications can help. We used to believe that this was going to be the mainstay of intervention, but we realized over the years that there may be hemodynamic correction, there may be changes in the bladder itself that are not affected by medication, and those changes can cause higher pressures or voiding pressures by thickening of the bladder. Remember from our last encounter, we talked about the bladder contracting against an open and closed door. Well, when that contraction occurs against a tight bladder neck from a large prostate, we get trabeculation or thickening of the bladder that causes thickening of the muscle wall. All these medications make us feel better and give us the impression that we are voiding better, but it doesn't do anything to alleviate the thickening or trabeculation of the bladder. And so what can occur is that 30 years ago, we used to think that this was going to obviate the need for surgical intervention. But what we found is that there are ongoing changes that are progressive, and there are eventually some kinds of surgical procedures or minimally invasive procedures that need to be utilized to stop the progression of trabeculation, stop the progression of high pressure voiding. So a lot of interesting things. You can see that there's a lot of interest. In the last few minutes, you've heard people calling me from all over the world to hear more information about these studies. So jump on in, get to the core curriculum, and we'll talk soon. Dr. Bill with just the tip of urology school.